Accordia, and thank you very much for inviting me to Galway to this wonderful conference. I'm going to be talking to you today about access to welfare in an era of superdiversity, and I'm going to cover a bit of ground. I'm going to start by thinking about the emergence of superdiversity, and then some background around diversity and access to welfare, what we already know, what the approaches to ensuring access are and the limitations, before I introduce the idea of welfare bricolage. So this is a new concept that we've been working on as part of a transnational project called UpWeb. I'll go through the methods for that project quite quickly, and then I'm going to cover some of the challenges faced by superdiverse residents and providers before talking about, well, you know, what does welfare bricolage do for us when we're trying to understand how people access welfare in superdiverse areas? And is bricolage a solution, or is it a sticking plaster for a failing system? Before concluding. Okay, how many of you have heard of superdiversity? Put your hand up if you've heard of superdiversity. Okay, maybe 50%. Maybe more, because some of you probably haven't put your hand up. How many of you have used it in your work? 2. Okay, that's okay. It's not compulsory. Just so I don't want to tell you things you already know. So I'll run very quickly through what superdiversity is, and I could talk for the whole hour about superdiversity, or probably all day actually. But let's not go there. Essentially, superdiversity is a large-scale demographic shift. It's been conceived as a movement from old to new migration, old migration being large groups of people coming from places where the West has post-colonial connections to just a few places. So you get these critical mass communities, large communities, which we've tended to create services around in the long run. The advent of new migration, which was a result of large-scale, spontaneous asylum seeking starting in the 90s, plus the economic boom and the demand for labour, really brought people from everywhere to almost everywhere. And that includes rural areas, and I know it includes Galway as well, because I've been chatting to, I think, Paul about this. What you see is the emergence of increased population complexity. And complexity and the complexification of family arrangements was something that I picked up from listening to the presentations yesterday. I am not a researcher of family, but I realise, having attended the talks yesterday, that family is inherent in all of my findings, whatever project I do. So now I'm thinking, okay, Sarita project, we're about to set some codes up for making sense of it. Family is probably going to be one of those codes now. Now, in terms of this increased population complexity, Steve Vertivec, who introduced the idea of superdiversity, talks about the diversification of diversity. And essentially what this is focusing in on not there just being more people from more places, coming to more places, but understanding that, you know, the idea of an ethno-nationalistic group doesn't necessarily hold up anymore, and that people's groups, if you like, are internally diverse. And they're diverse in multiple, ever-shifting ways. So, you know, we've talked for years in Birmingham about our South Asian community, but in fact that's 4 generations of people speaking multiple languages, attending different kinds of mosques or not having any religion at all, different levels of education and migration statuses, and all of those impact on their sense of identity, belonging, but also on their welfare needs and whether they have any welfare needs at all. On top of this increased population complexity, or very much part of it, is what Jill Valentine has called super mobility. And we have this increased mobility so that actually it's much less likely. We all move more than we used to, but for migrants, once you've moved once and you've got over that psychological barrier, it's now not necessarily the case that you will settle in, say, one part of Birmingham and stay there for the rest of your life, but you will move around in response to better opportunities, better housing, better social networks. And people maybe come and go, every year to take a seasonal job. We've got Polish doctors coming to Birmingham for the weekend to cover a shift and going back to Poland during the week. There's all kinds of arrangements. So there's this constant state of flux. Now, in another paper, I've written about the idea of novelty and newness and how for both service providers and for those who are seeking services, they both face this kind of ongoing challenge of novelty and newness, which I argue goes above and beyond some of the challenges that were faced under multiculturalism. The idea being that both service provider and user are encountering novel systems that they've never met before, and they have to make sense of those systems, but they're also encountering novel languages, novel cultures, and with the ongoing movement through super diverse areas, which tend to act as arrival zones or escalator areas, people move in and then move out once they're socially mobile, everything's always new. So if you're working in one of these super diverse areas, chances are you may only see this client or patient once or twice, and then they'll go and you won't know what has happened to them. And the same, of course, for the client, that they're constantly having to explain themselves and their situation to new people. Now, as things stand, we don't have a great deal of knowledge about health and welfare seeking, how that actually proceeds in super diverse neighbourhoods. So, I don't know, maybe 4 or 5 years ago, this was a question, a burning question for me. And I was fortunate enough to access funds via the Welfare State Futures programme to ask the question, how do residents in super diverse areas bricolage to address their health and well-being concerns? And it is this focus on that question that will shape my presentation today. Okay, so what have we done? What have we understood? How have we reacted to diversity in welfare needs to date? Well, initially, we ignored needs completely. We just made the assumption that migrants who arrived in pretty large numbers to our urban areas would go home after they'd saved up a bit of money, or that they would completely assimilate, and we wouldn't need to worry about integrating them into any of our welfare services at all. As time proceeded and we realised that people were forming these fixed communities and the communities were growing, forming critical mass, there tended to be a focus then on migrants as a threat, migrants and their descendants as a threat. So we looked at risky behaviours and we worried about those risky behaviours, or I don't know what the Irish press is like, but certainly the British press focuses on migrants as being undeserving. And there's a whole raft of knowledge around the concept of deservingness. And if you compare migrants to elderly, to ex-offenders and to other groups, they are seen by certainly the European population as the least deserving group. And there's been an argument that migrants are actually accessing too much welfare. You know, and this is a problem because they are undermining social solidarity. The idea being that we all use welfare at a similar level, and that way we are prepared to contribute to the welfare state and support its continuity. So the argument has been made that too much superdiversity means we don't feel a sense of social solidarity across the population, and we start to be reluctant to fund the welfare state. So we start to, it's a perfect justification for austerity. But certainly migration, superdiversity is seen as a threat to the welfare state. And so what we have seen as well in response to this is the emergence of the hostile or so-called compliant environment, the idea that we place restrictionism at the heart of our policy around immigration, and this prevents this reckless overuse of the welfare state. And it protects our National Health Service, that's how it's said in the UK, but also our welfare benefit system, and make sure that it only goes to the deserving. Now, I could talk forever about the hostile environment and how it's led to many people who are extremely deserving and clearly entitled to access welfare to be excluded. And I think I can't remember the numbers, but it's thought that several hundred people have died as a result of the hostile environment. Anyway, so these are some of the key issues around access to welfare. We can see that welfare and diversity are seen together as being a problem. And we're not in a position to compare what happens across Europe. Are some welfare states, the ones that are purportedly more generous, like Sweden, do they have better outcomes for their migrant groups, for their children, for their youth, for their elderly, than, say, the UK, where we have got this more restrictive approach? Because we don't have data, we can't compare. So we don't collect data in the same way. Where we all collect data, because we monitor, we all tend to use an ethno-nationalistic lens based around a certain number of ethnic or country of origin groups, which has essentially been blown out of the water by the emergence of superdiversity. So I work in a ward called Handsworth. I've been working there for about 20 years. And in Handsworth, you've got people from 167 different countries. It's quite difficult to perform any meaningful ethnic monitoring on that. And looking at the Irish data that John showed yesterday, I was intrigued because I noticed how your other category had increased markedly in, I think, about a 6-year period, from 40,000 to 70,000. When you have in your ethnic groups the other categories rapidly increasing, that's a sure sign that you've got superdiversity, because you can't classify those people who are coming in. Okay, so what have we done then when we've had this increased diversity and it's been a problem? Well, sometimes we've provided adaptations, so based around special needs. So we need in Handsworth, we had an Asian resource centre. We've certainly very much focused on the provision of interpretation in some countries, but other parts of, like some parts of the welfare state have hardly adapted at all. And they're based on the same system that they have been, where the welfare state originated. So Bahira yesterday talked about the idea that, how tricky it is to be a parent in a system that is predicated on the idea that there is someone at home who can attend those school appointments during the day. But it's not just that the system is gendered, but it's been created for a homogenous population. And a homogenous population that works 9 to 5 as well. So there's been very little adaptation apart from to add interpretation. And where we have in the past, used these ethno-nationalistic approaches, like particular centres for particular groups, where you have superdiversity in your 167 different groups, and then don't forget you've got the diversity within those groups, you cannot introduce special services. You need a critical mass for that. So it might work for, say, big groups, but it's certainly not going to work in areas where you have many people from many different backgrounds. So we have little understanding about how people access welfare from different backgrounds. And even worse than that, there's a tendency to look at how people access different parts of the welfare state, but not to look across the welfare state, because people tend to often use more than one part, or to look across the mixed economy of welfare. And this is where family fits and becomes really important, and that tends to be a neglected part of the analysis. So what we did as part of this project is to think about using the idea of bricolage to describe the way that people use multiple resources when they're living in super diverse areas, and to consider the reasons why they use those resources. So welfare bricolage. Bricolage is, as a term, I know you'll all be familiar with it. It's been extensively used, but it's not actually been used around diversity or welfare. If you look to the work of people like Levi Strauss and Deleuze and Guattari, you see a focus on bricolage as being process or on agency. So it focuses on tactics, it focuses on behaviours, patterns of thought, and what really appealed to me when I was pulling this all together was the idea of agentic mobilisation of multiple resources. So I like the idea that it could draw out agency and that it would move across resource sets, because as I've said, when looking at welfare and healthcare, there tends to be a siloing of different sets of resources in different places. Empirically, it's been used quite extensively in policy, in the arts, and in studying entrepreneurship. And it tends to be applied in relation to situations where there are a lack of resources or there are a specific set of challenges, and it tends to be associated with creativity and innovation or reuse of resources. Does anyone know Monsieur Bricolage? Have you come across Monsieur Bricolage? It's very gendered, I know, but very important person, Monsieur Bricolage in France, and I think he kind of sunk into my consciousness growing up as a child. I would see Monsieur Bricolage when I went on holiday, and it's the big DIY store there, and Monsieur Bricolage, he wears this toolkit, and I kind of, when I'm thinking about super diverse areas, I'm thinking of these as kind of people with toolkits and being able to work their way through the welfare state. So I think that kind of fed into the whole bricolage idea. Now, when it comes to thinking about super diversity, I argue that super diverse neighbourhoods offer a wide range of opportunities for bricolage. So quite often, these are what I've already called escalator areas. They're kind of quite poor areas with low levels of resources. People move into those areas because they're an affordable place to start your life in a new country. But they are poor environments, and they do have multiple challenges, one of which is the level of mobility they've experienced. But there are opportunities in these areas as well. 167 different countries of origin in Handsworth. That means different beliefs, different experiences of different welfare systems and healthcare systems, different experiences, different cultures, different knowledges. Surely these must somehow be put to use to address some of the kind of major social challenges that people face. And there are also these hubs where you've got, yes, local resources, but you've also got transnational and translocal resources. They all kind of come together in these places. So that also could offer an opportunity. So I try to invoke the idea of welfare bricolage because I believe it will help provide a lens to examine the combination of preferences, knowledges, constraints, purposefulness, and creativity that are enacted by individuals living in a super diverse neighbourhood to meet welfare needs. Now, you might think that as a professor of migration and super diversity, I'm only interested in migrants perhaps, or people from diverse backgrounds, but a point I should make, and this has been much debated around the issue of super diversity, is that super diversity tends to take a spatial focus, so it tends to look at a place rather than a group, so it shifts beyond existing ethno-nationalistic constraints, methodological nationalism, as Nina Glick-Schiller has termed it, and it focuses on what happens in a place. And I've tended now to describe these places as ecosystems, and I'm interested in what happens across these ecosystems. So I'm interested in everybody, whoever lives there. And super diversity captures the whole diversity of life within a place. And that's what I'll be focusing on. So here we have the Upweb Project logo. And just to give you a sense of what it looked like. And a very complex diagram of our methodology. I'm not going to go into too much detail, but just to cover the basics here. Now you can see at the top, obviously it starts with a literature review, blah, 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 they always do. But you've got 4 different cities. So you've got 4 cities in 4 different welfare states. So the intention was to compare welfare states. And we had 2 neighbourhoods in each of those cities, 2 super diverse neighbourhoods, one with a kind of positive social mobility trajectory, the other that had experienced long-term deprivation and was showing no sign of change. It starts with some street mapping and ethnographic work, so we're getting to know these areas. And I should say that this is what I've called a parallel sequential mixed methods approach. So you have to go through one phase to get to the next. So you have to do your street mapping and your ethnography to know how the area functions so that you can create your questions to ask the residents. We then did 160 very in-depth interviews using a maximum diversity sampling approach with local residents of all kinds of backgrounds. So we had a kind of grid, and we wanted to include the main groups, but lots of other people. We had migration status, we had education level, we had sexuality, we had dietary preferences, we had all kinds of things, and you're trying to tick all those boxes, because actually with maximum diversity sampling, what you're looking is not to use, say, culture, i.e. ethno-nationalistic groups, as the reason for selecting a group, but difference. Because if you find commonalities across such difference, then they have increased potential for generalisation. After the interviews, we analyse collectively, we then come together, design a new topic guide, this time for the providers. And then we go out and we interview the providers that have been identified by the respondents. We don't interview them about the case of the individuals we've spoken to. That would be an ethical nightmare. But we are interviewing them about how they provide services in super diverse areas. And then we work our way down, and eventually we end up spending a week in Hamburg designing a household survey that's a combination of long-validated epidemiological instruments and bricolage-specific new questions. And we end up with the final model in an ideal world. It wasn't quite as neat and tidy as that, I can tell you. And it was incredibly stressful. But there you go. So that's where the data comes from. I'll now move on to talking about the challenges faced by residents. I'm going to talk quickly about the challenges faced by residents, then the challenges faced by providers. And I think it's really important to have both those perspectives, because quite often it tends to be one or the other. And then I'll look at the solutions as well. As a social policy analyst, I am possibly one of the most guilty characters here, but we tend to just look at problems. And actually, the solutions are out there quite often in front of our noses. We don't do very much with those, and we do it for the best of reasons. So we do try to focus on solutions here, and maybe bricolage is a solution. Anyway, so what challenges are faced by residents? Well, the idea of complexity came through some of the discussions yesterday. But we have, multi-morbidities, multiple issues associated with complex social problems that relate to addiction, mental illness, physical illness, unemployment, homelessness, domestic violence, and sometimes all of those things at once. So hugely, really, really intractable social problems. There are structural factors. So we have the case of someone called Najet here. She's pregnant, she's living in Bremen, she's undocumented, but she's kind of a refugee at the same time, because you have this phase in Germany when you're sort of in between. She's pregnant and she needs food. She needs she needs a social worker to help her. She needs all kinds of things, but she just cannot access the system. So she's kind of outside of that. There are economic constraints, people who have no income or on very, very low incomes, working extremely long hours in very difficult jobs, low levels of satisfaction with systems, that people feeling, whether they're migrants or not, that the system doesn't meet their needs. And constantly, over and over again, we're told by residents that they are totally disregarded by health services. So, we heard people from every country say they do not take me seriously. And there's one example of a Palestinian chap who is suicidal and, self-harming, domestic violence, all kinds of problems. And he's seen by a social worker, and he says to the social worker, I pray so hard that I will get better. And the social worker laughs at him and says, well, that's going to make no difference. Well, that kind of undermined his relationship with his social worker and, caused a major rift. So, this kind of trivialisation and lack of respect for people's belief systems is a problem and is a challenge. Racism and discrimination, and that's, discrimination against sex workers, against people with addictions, obviously, a widespread issue. Uneven patterns of power distribution, people that are able to demand what they want because they have a sense of authority and a sense of entitlement, as opposed to those who don't. And then we see the effects of austerity, particularly in the UK, exclusively in the UK and Portugal, where the waiting times that people are subject to for even kind of quite serious things are very, very lengthy and, high degrees of suffering. So these are some of the challenges. If you're in pain and that pain stops you working and that pain stops you sleeping, you need to do something. And if the state isn't going to do it for you, you have to find a way yourself. And then we also have an issue which is kind of related somewhat to superdiversity, that you need a certain degree of what's called cultural health capital, but I think I've also invoked it to think about welfare health capital. You need to understand the system. You need to understand your rights and entitlements in order to be able to work within the system. And that isn't necessarily a migrant thing. I mean, there's a great example in Germany of a woman, we call her Kirsten. She's German-Turkish and she's had a terrible car accident and she has multiple care needs. And she is extremely good at identifying the different parts of the German system that can help her, but at the same time, it doesn't resolve her pain, it doesn't resolve her sense of loss at becoming disabled. So she chooses to have psychotherapy that she pays for herself, she prays, she travels back to Turkey, and she accesses different parts of the Turkish system that can meet different needs that can't be met in Germany. So she understands two, institutional cultures. And that really works to her favour. In terms of the challenges faced by providers, yes, superdiversity does bring a range of challenges. Communication, top of the list for all providers. We just don't know how to communicate with people. But actually, there are people who are not migrants who are not literate. So in Portugal, there's a whole swathe of elderly people who are not literate and have been left completely behind by the digital revolution. They just can't access anything at all, and they never will be able to. No amount of training is going to make any difference. We were told by a lot of providers that culture is a problem, that they behave in a certain way, like they don't turn up for appointments, or they turn up with too many kids, and we've only booked one, so that's kind of pinpointed as an issue. And the whole issue of cultural health or cultural health capital or welfare health capital, not understanding how to work systems, not knowing that if you go to a doctor in the UK, you've got 8 minutes to state your case, make your demands, and then you're out the door. If you spend too long there, then you will lose the attention of the general practitioner and you won't get what you want. And inflexible systems, so systems that are not designed for people who do bring 6 kids to an appointment. There's no flexibility there whatsoever. But, the challenges that we identified within these superdiversities go way, way, way beyond superdiversity. And I think it's important, to highlight the commonalities between the so-called general population and diverse populations. You've got high degrees of, very, very complex social problems that go beyond the remit of one provider. And the problem is that providers are faced with people who have maybe a very severe mental illness, and they know that underpinning that is poverty, is homelessness, as various other issues, and they have no power to do anything about that. So they know they're treating the symptoms but not the cause, and that is a major challenge for people who really care about making a difference in people's lives. Austerity, the fact that the services that we spoke to have had their hours reduced, have had their funds reduced, have had their premises taken away, major changes that mean that they really struggle to deliver the services in the way that they want to deliver them. The sheer poverty that's everywhere in super diverse areas comes out as a major theme. And for state providers, managerialist approaches that put more focus on bureaucracy, numbers, targets, etc., than on people is a major, major distraction. And some providers tell us we try to avoid taking cases like this because it takes us 3 hours to do the paperwork. So this is why people get trivialised. This is why they get sidelined, because the providers don't have time. Okay, so what do people do when they're faced with these kind of problems? Well, what do residents do? In particular, residents can adopt what we've called 4 different strategies, and I've developed these in a much more detail elsewhere, so it's difficult to go into them in any depth. But actually, some people don't really do much at all. They just kind of stick with the state system, and sometimes that works out well, sometimes it works out really badly, but they never deviate beyond that, partly because they don't know how to, or sometimes because, and let's talk about the positives, they're incredibly satisfied. They're getting everything they need, it works for them, and that is wonderful. The most common approach that we identified is where people bricolage within systems. So they cannot cope with the state system by themselves. They need support. And they use a whole range of different resources. So sometimes that's about maybe using the internet quite extensively so that they can do some research before they make a particular request, ask for a particular benefit or whatever. But often a really important part of this is using what Green et al. Have called a navigator. And families are often the navigators. So we have a Somali woman in Sweden, and she keeps having this like really dizzy kind of feelings and falling over, and she's really worried, and she doesn't know how to deal with this. So she talks to her daughter, and her daughter Googles her symptoms and her medication, and her daughter rings up her mum's doctor and says, "My mother has these symptoms. The medication you've given her isn't working. You need to give her a new medication. I suggest you give her this one." Yeah. And doctor goes, "Yeah, okay then." Works for him, because I assume it's a him. Sorry, I don't know. But that kind of navigation is really, really important. If you've got someone who's there who understands and who can make demands, personality is an important part of it as well, then you get this within system bricolage, and that way you can optimize how the system works for you. We also see a significant proportion of people who are bricolaging in addition to the system. So they're using multiple additional resources. So they may pay for additional services to help them. We have, there's a Vietnamese woman in Birmingham, and her father's got dementia, and he has a high degree of social care needs, but he's quite difficult to work with. And she buys in all these additional services and doesn't choose to use the state social care system because she's dissatisfied with the level of care that it offers her father, the fact that it doesn't provide the languages that she wants. She wants a carer that speaks a particular language. But she's still engaging with his social worker. She's still engaging with his hospital. So she hasn't gone completely outside the system, but she's adding bits and pieces all around it. And of course, she herself, the daughter, father lives with daughter. She's a very, very much part of that bricolage. And then you've got people who bricolage instead of the system, and they use multiple resources. So for those individuals, I've got an example of someone we've called Pedro. He's Mexican. He's been told, he's only 26. He's got this terrible tinnitus. He can't sleep. He can't concentrate. He's really having a rough time of it. He's been told it's totally incurable. Get on with your life. And he doesn't want to do that. He can't do that. So he lives in a super diverse neighbourhood, a place called Moreria, and he talks to his neighbours. And his neighbours give him tea and balms that he can try. He gets a private appointment somewhere. He goes back to Mexico to try the service there. He does Chinese medicine. He does all kinds of things. A kind of bricolage of desperation, you might say. So what do providers do when they're faced with these issues? Well, when it comes to communication, which is their biggest bugbear, some turn people away. Come back with somebody who speaks German, and that's that. You may have a problem, but not my problem until you can communicate with me properly. Others are much more creative, so we see a lot of use of technology. Lots of people have designed little signs so you can have smileys and different, point to different parts of the body, and you can scale the level of your pain, all this kind of thing. So lots and lots of creativity there. We find that providers are connecting across, I'd call welfare ecosystems. So they're sharing resources like, I know this person over here has a member of staff who speaks Turkish. So I will go to this other surgery or the pharmacy. And they don't officially have sharing arrangements, but they do share. And they work together, particularly with third sector organisations. They outreach. So they, if an organisation is known as having a specialism with people who've got addictions, then you might find the state going into that service to provide support and guidance for people that won't come to their surgeries, if you like. So you have all this kind of reaching out and reaching into different places, and organisations get a reputation, well, we know that person is well connected with this group, this network, and so on. And we saw the development of new ways of working. So where resources are tight, we saw a shift as demand increased from individual approaches to supporting families, particularly to group approaches. So creating groups that can support each other, also moving away from fixed hour clinics and appointments to having drop-ins and flexible hours, introducing stuff in the evenings and stuff like that, so being flexible there. And one of the biggest approaches that was really quite striking and made a huge difference was how either third sector organisations, but sometimes the state, were collecting donations and using them to try to address some of the worst edges of the kind of poverty that were experienced by some of their clients. So we've got a third sector organisation here in Portugal, and what they've done is they've got this brilliant idea, because people just can't afford medication. They cannot afford their diabetes medication in Portugal, and we all know that that's not going to end well. So what they do is they're collecting out-of-date medication, or medication that's nearly out of date, from all over the place, and putting it on a shelf and having this kind of informal pharmacy arrangement so people can access that. We've got a paediatrician who knows that some of her clients cannot afford nappies for their babies, so she goes out and collects nappies and baby food and stuff like this. So different ways of providing. We also see across each of the 4 areas, but less so in Sweden, that third sector organisations are the ones that are filling the gaps. They are the ones that deal with the everyday complexity that is beyond the reach, beyond the grasp of certainly state providers who have fairly narrow remits and inflexible roles. So they provide individualised care. They take the person, they look at the person, and they think, okay, what are these problems? And either they connect it with other third sector organisations that can help, or they provide volunteers. So on our website, there's a Welcome Project. There's a film on the Welcome Project. The Welcome Project is a little Friday lunchtime thing, and into this comes asylum seekers, refugees, and local people who are volunteers, but who are actually themselves quite isolated. They all eat dinner together, and through having this dinner kind of get together, they learn about each other's problems. And then gradually they provide volunteers who can help with the various different problems. In the end, you find that some of the volunteers end up offering a home to the homeless asylum seekers. They end up helping with legal problems, providing clothes for children, and so much more. So it's really individualised. Often offering home visits, that becomes completely, particularly important, and offering empowerment and voice, giving people the opportunity to at least talk about what their problems are, and at least have the hope of finding some kind of solution. Now, I put a quotation here from the Misericordia, which is a charity parallel kind of health and welfare system in Portugal, and the way they act is so very, very, very different to the mainstream Portuguese state. And this nurse talks about how they actually go to people's homes and they ask people, how are you? That simple question, how are you, can often invoke major tears, and nobody's asked me this before. And it's it is reassuring, so it is really, really important. In terms of formal providers, it's very tricky for them to have much flexibility, so they kind of, they extend out over the ecosystem to third sector organisations, and some of them bend the rules a bit, but other than that, there's not much they can do. Okay, so in discussion then, what we identified with our maximum diversity sample is that there are common challenges that cross the 4 countries and cross groups, if you like. So one of those challenges is communication. It can also be lack of documents, and it can be complex problems. It always invariably is complex problems in a system that's designed for a homogenous population in a time, I think, where there were more jobs and there was at least more resource put into welfare states. So there are challenges that are associated with superdiversity, but one of the things that comes out of this project and this kind of, the spatial approach is that the challenges go way beyond superdiversity. And I think as, certainly when we're lobbying for change, where we have hostile environments like those in the UK, it's important to focus on those commonalities between groups. And, we see that where there are elderly, where there are people with low levels of education, literacy, where there's poverty and where there are entrenched social problems, actually the welfare state is not providing for those people either. And this homogeneity does not work for them either. And, I've shown you that bricolage can be a solution. It can be a way forward. And importantly, it's a form of agency that enables people to feel like when they've hit a brick wall, that they have at least some hope, not necessarily of a resolution, but of things improving a bit. But also we saw that bricolage is often an act of desperation. It's a last resort. It's, I don't know what to do. Nobody else is there for me. And it's important to bear in mind that for some people, well, they don't bricolage, but for others, they don't ever find a resolution and they give up. And the system, if you want to call it that, is littered with people who have tried and failed and given up and are just suffering and getting on with it. And we found plenty of those, as well as people who fared well. We also found that those providers who were busily bricolaging, they were working hard to connect people here, there and everywhere, the ones who were working for the state but trying so hard to address these multiple problems, had experienced very high levels of burnout. So this is not a sustainable solution unless we provide more support for those staff. And so they are confronted with either becoming ill and leaving, and we saw that, or lowering their expectations, because a lot of people just want to get out there and solve those problems and help people to resolve their situation. Lowering their expectations could mean, and people told us this, that they became racist. I start to resent these people because I know if that kind of family walks into my surgery, then it's going to mess up the whole morning and it's going to do it for everybody there. And they say, this has happened because I'm under so much pressure. It's not an excuse, but it's a reality. So, in conclusion, what about bricolage? I think, bricolage has highlighted quite a lot of potential for innovation in existing institutional systems, and to show that there's a great deal of flexibility in the relationships between providers and users, and that can be a source of creativity and innovation. But, we're left with the question, is bricolage, and the things that people are doing, is it just a sticking plaster for an outdated system? Or is it self-empowerment? Or is it just a natural outcome of neoliberalism? And, we've written some papers focusing on the kind of politics of bricolage, which I don't have a chance to go in today. I think we've got potential to see bricolage as a form of resistance. And I think that we can use it to say, look, this is what's going on because of the shortcomings of the state. But we have to be careful not to romanticize it and say, look how these people are amazing, they're doing this and they're doing that. Because actually, as I said to you, it's a sticking plaster at the end of the day, and a lot of people don't get anywhere. What bricolage has enabled us to do, and I continue to push this one, is it's moving us away from problematizing groups of people to problematizing the system that is failing those groups. This homogenized, fixed system that is out of date and needs more than just tinkering with. So I think there's plenty to do here in the future if you're interested, that you can use the idea of bricolage if you want, in a whole range of different settings. It can work with youth work, it can work with child protection. We're starting to do some work around child protection. And as yet, we haven't really been able to pin down what is not bricolage. So in other words, we haven't defined it very well yet. So there's plenty of work there. Thank you.